again, I want to thank you for giving me this opportunity for sharing all those information worldwide. And for this presentation in specific, I'm here on behalf of a cardiologist colleague, Giuliani Raffel. Those three patients are from her, but due to clinical issues, she could not be here with us today. So I'm going to share her presentation of his bundle pacing and left bundle branch pacing, a physiologic stimulation. So we all know that the pacemaker syndrome is a complex of symptoms consisting of heart failure, near fainting, sensation of pulsation in the neck or abdomen, cough, which develop or are aggravated after cardiac pacing. Objectively, a fall in systolic blood pressure is observed in the majority of cases, and also canal wave in the neck vein, signs of heart failure, retrograde arterial activation, and possibly canal wave in the central venous pressure. The condition is most probably caused by a lack of atrioventricular synchrony with resultant distension of the atria, which will result in a reflex-mediated decrease and defective increase in the total peripheral resistance, and thus a fall in systolic blood pressure. Treatment will consist of establishing normal atrioventricular synchrony, and this is where we are. So her abstract was about 3 patients that she put his bundle pacing instead of the ventricular pacing. So we know that the cardiac pacing in the treatment for patients with severe bradycardia or AV blocks. It is also known that 20% of the patient requiring more than 40% ventricular pacing may develop pacemaker syndrome, mainly in those with structural disease. In order to reduce the synchrony that we said that was the most important thing to develop the pacemaker syndrome, the implantation of the ventricular electrode in the his bundle and left bundle branch emerged as an alternative for physiologic stimulation and improvement of the desynchronism with narrowing the QRS. It also known that physiologic stimulation can be an alternative to resynchronization with improvement in cardiac function by improving synchronism. In this work, we are presenting 2 cases of successful his bundle electrode implantation, maintains of a narrow QRS similar to physiological, and 1 electrode in the left bundle branch with significant QRS reduction and significant improvement in ejection fraction, with normalization of the left ventricular function 7 days after the implantation. The main of this work is to present 3 successful cases of physiological stimulation and show that this method is safe, fast, and beneficial to the patient when performed by an experienced team. So I'm going to show the follow-up of her patients. So one of the 3 patients had left ventricle ejection fraction less than 40% at the implant. And then this patient has an improvement of more than 50% of LVEF in the follow-up of 7 days. Another good thing is all 3 patients had an improvement in New York Heart Association functional status. And also all the QRS were narrow at the presentation, and the paced QRS remained narrow and stable during the follow-up for 1 month. So here we have a basal EKG from one of those 3 patients. And here we have the base QRS, the base EKG. So in this one, the QRS has 95 milliseconds, which again, we all know that the QRS remained narrow after the use of the electrode pacing. So for the conclusion, as a direct consequence of increasing adoption of his bundle pacing, there is a need for more widespread awareness of EKG analysis and specific programming requirements relative to this therapy. We know that the system configuration leading its unusual program settings, and this can be confused to a lot of cardiologists. So there is no doubt that we all are going to adapt this technology to meet the new challenge that we have in programming the his bundle pacing and left bundle branch pacing. So in meantime, while the technology is developing better for this situation, we need to familiarize ourselves with HBP programming to ensure safe and effective therapy for our patients. Thank you.
Okay, thank you, Dr.